You're not audible. You're not audible.
Tiwari sir is busy in some meeting. I just talked with him. So he said that
Acha,
you
acha.
start.
Hmm. तो, before you introduce Professor Nandini to the audience, I think as the course director, I wish to extend heartfelt thanks to Dr. Nandini for sparing valuable time and to be part of this course program of ICP. Uh, Dr. Daria?
Yes, sir. Uh,
Yeah,
Thank you
I
so much,
think.
sir. On the behalf of Dean ICP, Dr. Kamlesh Tiwari, sir, and Dr. Sudhir Mehta, sir, I welcome again you all in this short certificate course of ICP. So today with us is none other than Dr. Nandini Chatterjee, ma'am. She is professor in the Department of Medicine at the IPGMER SSKM Hospital, and she is the editor of Bengal Physician Journal. She is a governing body member of API, scientific chairman API West Bengal. She is a regional counselor international RCP of Glasgow, and she is also a co-chief editor, Southeast Asia edition of McMaster Textbook of Medicine, editor of monograph on art of scientific publication. She has done a lot of clinical trials also, and she has been a part of clinical compendium on mucormycosis, practical standard prescriber 10th edition, and tropical fever dengue 3rd edition, and approach to a differential diagnosis. Publication is various national and at the international journals. So I welcome you, ma'am. Thank you for accepting our invitation for this short certificate course. So over to you, Dr. Nandini Chatterjee, ma'am.
Thank you, Dr. Daria. First, Dr. Jyotirmoy Pal, President
Yeah.
API, sir, he has
Sudhir
joined.
Mehta sir, Dr. Jyotirmoy Paul sir is here. Please introduce him also. Requesting Dr. Sudhir Mehta sir.
Dr.
Am
Mehta.
I audible? Yes. Am I audible?
Yes, sir.
Yes. Welcome, Dr. Jyotirmoy
Yes,
Paul.
sir.
He is the president, API Association of Physicians of India, and a dynamic physician and academician. I think I have known him for over last 10, 15 years, and his energy level, I think, is probably the one of the best in the body, that is the API. I've never seen such a dynamic and person who always works for the to what you call contribute to the knowledge of the physicians and the PG students who are part of the API. Welcome, Dr. Jyotirmoy Paul. I think few words of wisdom and blessings to this program would be appreciated by all of us.
Yes, thank you, Dr. Mehta. As President of API and Chairman ICP, I am very happy that such a short certificate course has become popular in India in last 3 to 4 years. And also the students and members are much benefited from different type of courses we undertake, starting from infectious disease, topical disease, cardiology, diabetology, hematology, from different segment. Our dean has selected, chosen different certificate courses. I am very happy. I see the huge enthusiasm among the members and students to be updated with different these courses. And I wish all success of such courses. Today, today is a very important topic, very frequently challenging situation we face. And Professor speaker is none other than Professor Nandini Chatterjee, who needs now no introduction in API. So over to Dr. Mehta.
Yeah, thank you, Dr. Jyotiboy, for your kind words and words of engagement for this program. And in fact, you are absolutely right. Over the last, this program has become very popular among the PG students and physicians in India. I think it is a very important way of imparting the new advances in the management of various common diseases and different disciplines of medicine, clinical medicine. I think with this, I'll request Dr. Nandini, Professor Nandini, to kindly deliver the lecture. And at the end of the lecture, Dr. Daria will moderate the questions which have been posed in the chat box. Thank you. Over to Dr. Professor Nandini.
Thank you, sir. My regards to Dr. Mehta, and also many thanks to the ICP and ICP Dean, Professor Kamlesh Tiwari, for inviting me to take up this topic. The topic today is a difficult one. However, awareness about this entity is very important, because unless we have a clinical suspicion, we may miss this, because it also mimics certain other related conditions. So without much delay, I'll be sharing my screen now and start on the
पल्स कितनी है? हेलो,
is this visible?
Yes, ma'am.
But the whole screen, I think, is not coming. Is it coming, the whole screen?
Anand, help, ma'am. Anand. Yes, you can do
मैम
it on slide share.
स्लाइड शो मैम स्लाइड शो में होगा सर फुल स्क्रीन।
Wait, I'll start again. But why the full
Here, yes,
not coming?
slide show.
Kaushik,
Ma'am, on the top one, na, this is slide show. Yes. Next, 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 next. Slide show is on the top. On left one, left one. Yes, yes, yes. Slide show. Starting from verse.
यस मैम।
Now it's okay, ma'am. You are muted, ma'am. Voice is not coming.
okay. So as we begin the discussion on the topic of today, I
Yes,
decided,
yes, yes. Now it's visible.
yeah, starting with a couple of cases and then build up on the cases to get into the subject proper. So we had a 25-year-old male who
Yes.
presented with history of fever, joint pains, myalgia, and vomiting for a duration of 6 days. When we examined him, he had tachycardia, his blood pressure was 90 by 60 millimeter mercury, his respiratory rate was 20 breaths per minute, he had high fever, saturation was normal, and there were no rashes on the skin or lymphadenopathy or cyanosis or edema. We palpated his abdomen. There was hepatosplenomegaly. Other systemic examinations were normal. Fundoscopy was also done. That was within normal limits. So, when we have such a case of fever, we give certain investigations on the first run, and foremost is the complete blood count. So as you can see, the complete blood count revealed that his hemoglobin was 8.8, The total count was only 2000 per cubic millimeter, and the platelet count was around 84,000. The electrolytes, the renal function tests were more or less normal. However, in the liver function test, we found that the transaminases were raised. The common organisms which are to be mandatorily tested in any patient of fever like malaria, typhoid, scrub typhus, and dengue were done. Of these, the dengue IgM came out to be positive. So, what are the issues that are at hand? We have a young person who is having continuous fever for 6th day, and that fever is of high degree. He is having body ache, joint pains, hepatosplenomegaly, and as the investigations revealed, he had pancytopenia and a deranged liver function test. So, what will you suspect? So, this is a patient of dengue. Did he develop a secondary bacterial infection? Is he having an expanded dengue syndrome? Or is he having another well-known entity, HLH or Hemophagocytic lymphohistiocytosis? So we will be finding about that. But first, let us also examine another case. This is a young lady who presents with fever, but this fever is for 15 days. She also has polyarthalgia and a new onset of shortness of breath and drowsiness, for which her family has quickly brought her to the emergency. She has a heart rate of 120 per minute on examination. BP is on the lower side. When we measure her saturation, it is 91% only. High respiratory rate, high fever. Full examination of the patient reveals that she also has lymphadenopathy in the cervical and axillary regions. Auscultation of chest reveals bilateral crepitations. Examination of the GI system, it's wrongly written abdomen. Examination of the GI system reveals that there was an oral ulcer on her palate. There was hepatosplenomegaly. As I have already said, the patient was drowsy, so she had a low GCS. However, there was no neck rigidity or no focal neurodeficit. Her fundoscopy was normal. Again, the same set of investigations I have put up in this slide. So her complete hemogram again reveals that her hemoglobin is low. Total count is even lower, 1000, and platelet count is 60,000. So quite marked pancytopenia. Electrolytes, renal function tests normal as yet. However, transaminases again are markedly raised. The fever etiology markers, malaria dual antigen, scrub typhus, diphtheria, dengue, all come out to be negative. Chest X-ray was done and it revealed bilateral infiltrates in both lung fields. So we went through her previous documents. She was not on any medication, but an old document revealed that she had a positive anti-nuclear factor 3+ homogeneous pattern. We sent an ANA profile. What are the issues in this second case? Well, she also has high fever and it is continuing for a longer duration. She has joint pains. Along with it, we detected an oral ulcer. She has hepatosplenomegaly, lymphadenopathy, along with pancytopenia and deranged LFT. Now, what to suspect in this case? So, young lady with the features as described before, we think that she is suffering from some connective tissue disorder. But not only that, what has happened to cause such fever and such new findings? Well, is he suffering from some extensive sepsis, or is it a flare of the disease, or is the patient suffering from a macrophage activation syndrome, which is none other than a different name given to the entity HLH in case of autoimmune diseases. So, to summarize, I have put before you two cases, one a case of dengue, another a case what appears to be of an autoimmune disease, most probably SLE, who are having pancytopenia, fever, organomegaly, altered LFT, and we need to think what has happened to them. Now, as our topic of discussion today is HLH, so let us now learn something about the disease itself, and then we will again come back to these two cases. So what is hemophagocytic lymphohistiocytosis? Well, it's a huge name, but a short form to which I will be referring to from now on is the HLH. It is a hyperinflammatory condition which results in increased phagocytic activity and with a lot of tissue damage, multi-organ failure, and at times death. During the COVID pandemic, a terminology came into being that was cytokine storm. So cytokine storm can be compared to, or HLH is a type of cytokine storm which results from this dysregulated immune condition, and we will be talking about it as I progress. Now, there are two types of HLH which has been described. One is the primary one, which is resulting from various genetic mutations. Another is a secondary one, and an inappropriate host response to either infection, some malignancy, or some autoimmune disease. Primary HLH is a rare disease, and its estimated incidence is 1 in 8 lakh per year, and it occurs in children. In adults, what we see is the secondary HLH. However, it is very difficult to accurately estimate the incidence of secondary HLH. This is because the presentation of secondary HLH is indistinguishable from the underlying trigger, that is whether the patient is suffering from an infection or malignancy or autoimmune disease. Sometimes these conditions itself can produce similar picture. Moreover, all the lab investigations that are prescribed to detect and confirm HLH may not be available in many places, therefore it is not done. Some estimates place it at 1 in 2000 for adult critical care admissions. So, a rough estimate of the incidence is given here, though it may be much more because these cases are often missed. So, few words about the primary HLH. As I have already mentioned, there are genetic mutations. Various types of syndromes also are said to be culprits for primary HLH. So, the Chediak-Hegacy syndrome, the Crisselli syndrome, the Hermansky-Pudlak syndrome, they are certain syndromes which may present with HLH, and there are a group of familial variety of HLH as well. Most of them are autosomal recessive in inheritance. The names of the genetic mutations are written in this slide, and I will also tell them, but I do not know whether the students will be able to remember them when they are facing their examiners. However, it is good to know that the commonest genetic mutations are mutations in the PRF1 and the UNC13D genes. Many other genes have been incriminated, but it is again, as I said, very difficult to keep them in your memory for a long time. What is more important for the adult patients that we physicians encounter is the secondary or reactive hemophagocytic lymphohistiocytosis. The primary HLH usually patients are going to the pediatricians, but we are encountering the secondary cases. Firstly, they may be happening in case of various infections. What infections? One of them is a very common infection that we face in India, that is tuberculosis. It can happen in various systemic fungal infections as well, one of them being histoplasmosis. In HIV infections, in EB virus, CMV virus, dengue virus infections, they have been reported. Of them, the EB virus or the Epstein-Barr virus infection is notorious to ultimately often lead to this condition. Though EB virus is often an innocuous infection with very mild illness in most of the cases. What malignancies lead to this condition? Mostly the hematological malignancies, the natural killer cell lymphomas, the B cell lymphomas, commonly the large B cell lymphomas, or the anaplastic large cell lymphoma and lymphoblastic lymphomas can have such presentations. Autoimmune disorders, I'll be coming to which ones are more prone. They can cause. Also, it can happen in patients who undergo transplantation or are receiving monoclonal antibody therapies. HLH, that is secondary to rheumatic or autoinflammatory diseases, are usually referred to as the macrophage activation syndrome or MAS. So it has been described in patients with SLE, with systemic juvenile idiopathic arthritis, Sjogren's syndrome, sarcoidosis, and Kawasaki disease. So autoimmune diseases, patients of autoimmune diseases who present with gross pancytopenia, we may keep it in mind whether they are suffering from MAS or not. So now some slides about how this develops or what is the pathophysiology. Now, in the healthy individual, a natural killer cell and cytotoxic lymphocytes are responsible for inducing apoptosis or cell death in the macrophages to maintain homeostasis. Now, macrophages are useful in countering infections, but if they start working too much, then they are dangerous for the body. So, there is a delicate balance that is to be maintained. So, the NK cells and the cytotoxic lymphocytes, they maintain this balance. Now, these cells, they create certain pores on the walls of the macrophages via a protein, the perforin, and various enzymes are produced that can cause the macrophages to lyse. This is the physiological thing by which macrophage activity is kept in check or kept in control. However, if due to some reason this negative feedback mechanism is hampered, then there will be excessive proliferation of the macrophages and they start producing large amounts of interferon gamma, IL-6, TNF alpha, and various other cytokines. All these cytokines will produce a massive inflammatory reaction and ultimately lead to tissue destruction. Also, when these macrophages become overactive, they start a process which is called hemophagocytosis. These macrophages then phagocytose various blood cells, including the WBCs, the RBCs, and the platelets. And this can be reflected if we do a biopsy of the bone marrow or the other organs like the spleen or liver or lymph node. So now we have described that what basically is happening in such patients at the tissue level. Now, once this process comes into being, what are the symptoms and signs of the patient? The patient develops high fever because this is a hyperinflammatory state. There is hepatosplenomegaly, wide or pancytopenias, and as there is so much of inflammation, we get high levels of ferritin, hypertriglyceridemia, low platelet counts may lead to bleeding, and as I have already mentioned, in the bone marrow, spleen or liver, we can demonstrate hemophagocytosis. This condition is a multi-organ pathology, and if we do not check its progression, then ultimately each and every system of the body is affected. The lungs can develop ARDS, the heart, a myocarditis, the kidneys may develop microangiopathies, the brain stops functioning, there can be a kind of encephalitis, the liver can also start failing, acute liver failure. So you can well understand how dangerous this condition can prove to be and ultimately may remain fatal. The overall mortality of this condition is very high, roughly around 41%, though it has been seen that sometimes adults can have a spontaneous remission, and a very large multi-center case series in the States have shown that the poorest survival rates are those who have malignancy. So malignancy associated HLH is the worst type of HLH, and their median survival is only 2.8 months versus 10.7 months in HLH caused by other diseases. So in order to diagnose this, because this is very important to suspect it and diagnose it early so that you can intervene in some way and check the progression of this condition to involve all organs. So there has been development of certain diagnostic criteria. Now, in 2004, the HLH diagnostic criteria was done mainly for the primary HLH, where they have said that you can diagnose HLH if you have either A or B to be fulfilled. What is A? A is molecular diagnosis consistent with HLH. As I have mentioned, in primary HLH, there are specific mutations that if identified, then it will have a confirmatory diagnosis. However, if you cannot go for the molecular diagnosis, you have to satisfy 5 out of the 8 clinical and laboratory criteria, and then only you can say that your patient is suffering from HLH. So as you can see, these criteria, fever, organomegaly, cytopenias, triglyceride raised, fibrinogen, whether it is decreased, hemophagocytosis, high ferritin, and also the last two, an elevated soluble IL-2 receptor and an absent or decreased NK cell function. Now, why are the last two specially marked? It is marked because these two tests are often not available in most of the centers. However, the first 7 are available, and you have to satisfy at least 5 of them to say definitely that your case is suffering from HLH. As you can also see that hemophagocytosis demonstration is not a mandatory criteria. It may be present, it may not be present. However, if you can satisfy other criteria, you can come to a diagnosis. The AIDS score. This score was devised specially for the reactive lymphocytic histiocytosis, which happens in adults. And here, the criteria for molecular diagnosis is removed. We only need to know whether your patients are having any underlying immunosuppression or not, and the rest of the criteria are similar. The difference from the 2004 diagnostic criteria is that here it is in a better form. It is a graded scoring system, and according to the values found, you have different types of scores. It is said that if your AIDS score is greater than 169, greater than equal to 169, then it is a confirmed positive case of secondary HLH. If the AIDS score is less than 169, it is not confirmed. This value 169 has been found to have the best cutoff value with a high degree of sensitivity and specificity. This was done by Fardet et al. The Fardet et al. They had started this scoring system, and it is a great way of diagnosing and finding out whether your patient is suffering from HLH or not. Investigations are to be done to find out whether the patient is actually suffering from the disease. I have already mentioned they are part of these scoring systems. The added investigations which are written on the right side are in order to find out what is the etiology of this condition. So you have to find out whether any bacteria, fungus or virus is responsible for that. If you are suspecting an autoimmune disorder, you may have to go for the anti-nuclear antibodies, their profiles and anchor testing. If you suspect a malignancy, then you have to go for a PET-CT, a biopsy or tumor screening. The gene sequencing test is only if you encounter a person where you are suspecting a primary HLH. So let us come back to our cases, the case 1 and the case 2. The case 1, you can remember, was a young person with dengue. That patient had transaminases much raised than normal. He also had pancytopenia, and we were thinking whether he is developing an infection, a sepsis, or an expanded dengue syndrome, or an HLH. So, a procalcitonin was ordered, which was well below the cutoff value, which means likely the bacterial infections were not there. The ESR was low. It was lower, on the lower side. It's only 77 millimeter per hour. And what we found is that when we went for the triglyceride and ferritin levels, they were much increased. The serum fibrinogen was less than the normal value, which is 150. So the serum fibrinogen was less, ferritin and triglyceride were high, and the procal and the ESR were within normal limits. So we concluded that this was a case of dengue with secondary HLH. Coming to the case 2, that patient, as I said, was also having lymphadenopathy, hepatosplenomegaly, pancytopenia, along with transaminases, which were much raised. However, when we did the specific investigations, again we found that the triglyceride, ferritin were very high, serum fibrinogen was low, procalcitonin was normal, ESR was on the lower side, so there was no sepsis, and we also wanted to find out whether this patient was suffering from SLE or its flare. So we sent the urine, we did a 24-hour protein testing and the ANA profile. So it was found that she was not in any kind of flare. So it was a case of SLE, but not an SLE flare. So again, the diagnosis was a secondary HLH in the case of an SLE patient. So when we did all these blood tests, we were more or less sanguine that they were suffering from HLH, but still we wanted to do the bone marrow to have further confirmation. In the first case, the marrow demonstrated hypoplasia. There was a suppressed marrow cellularity, but no hemophagocytosis. In the second case, which was of SLE, we found that there was hypoplastic marrow, but features of hemophagocytosis inside histiocytes. It was found that there were mature erythrocytes, platelets, and leukocytes inside the histiocytes. So, what I want to stress upon is that in order to make a confirmatory diagnosis of HLH, you do not need to always demonstrate a biopsy specimen where there is hemophagocytosis. If you can show that there are around 5 out of the 8 important diagnostic criteria, then we can say that the patients are suffering from HLH. So, having diagnosed the cases, it's time to discuss the treatment principles. The principles are immunosuppressive therapy, treatment of the cause, stem cell transplantation in the people who have familial HLH, and of course, very importantly, supportive care. Supportive care in the form of transfusions, antibiotics, and proper ICU monitoring. So, immunosuppressive therapy, what are the drugs that are usually given? Now, it has been said that the therapy has an induction process and a maintenance process where required. The induction therapy is of 8 weeks, where you will give both dexamethasone and etoposide. Dexamethasone is given in the first 8 weeks in a decreasing dose, either orally or IV. Most of these patients are so sick that we will go for the IV dosage. Here we can give first 2 weeks will give a 10 milligram per meter square, then we gradually decrease it to 5 milligram, 2.5 milligram and 1.25 milligram until we complete 2 months of therapy. So this is the steroid part. The next drug that is important is the etoposide. Etoposide again should be given initially twice a week for the first 2 weeks and then once weekly for the next 6 weeks. Dosage is 150 milligram per meter square for adults. This dose may have to be adjusted if there is renal dysfunction. After 8 weeks, patients who have sporadic HLH, usually you stop the therapy. However, in case of familial HLH, you may need to go on with a maintenance therapy, or if there is a persistent disease, again, you will have to continue with the maintenance. The maintenance is continued with the help of dexamethasone in pulses every 3 days and weekly treatment with etoposide. Now, in case of familial HLH, because these are children who need lifelong therapy. So that is not a very good way of spending one's life. One of the best options is to offer that child an allogenic hematopoietic cell transplantation if it is feasible for that patient. This will often lead to the cure of the patient. If the patient has CNS involvement, then intrathecal methotrexate also may be needed to be administered weekly. Now, a few slides about certain other drugs which have come into use. Some of them are experimental too, but as we know that we need to have an idea about some of the newer therapies that have come up, and of them the emapalumab is a human IgG monoclonal antibody which targets the interferon gamma. And as I had described, the interferon gamma is a very important cytokine from which the activation of the other cytokines occurs. So if we can target interferon gamma, it may help in somewhat neutralizing the activities. So it is the first targeted therapy which has been approved for HLH treatment, and it is especially beneficial to patients who are unresponsive to conventional treatment. There are many other drugs which some of them have been used during COVID times, like the IL-6 antagonist tocilizumab. It has been found that some patients have responded to tocilizumab therapy. Some JAK2 inhibitors are also being tried in mice. It has not been used in humans as yet. So these are all in the experimental stage. Some other drugs like anakinra, rituximab, alemtuzumab, all these drugs which are used in autoimmune diseases or autoinflammatory conditions are being tried and seen whether they are helpful in HLH or not. For the primary HLH, however, since this treatment has to go on and on, we have to resort to a stem cell transplantation. Gene therapy utilizing virus vector mediated gene inculcation into the stem cells has also been tried out. So I have come to the end of my talk. To summarize, first thing is that the HLH entity has to be suspected. And when will you suspect it? You will suspect it in a febrile patient who is having a rapidly falling blood counts. Moreover, we will suspect it in patients who have underlying malignancies or underlying autoimmune disorders. It is very important to recognize them in a timely fashion, because the intervention, if it is coming in a later period, then it will lead to multi-organ failure and fatality. The diagnostic criteria are very, very useful, and most of the investigations are easily available so that you can stamp them as case of HLH. Of course, the bone marrow is a risky and invasive procedure. However, as I have mentioned, the bone marrow hemophagocytosis is not a mandatory criteria for confirmation. Multidisciplinary approach is required for the management. However, as we all know, as yet, it is a condition with poor prognosis and high mortality. So thank you for your kind and patient listening.
Thank you so much, ma'am, for an excellent presentation. I think everybody will be agree with me that we are seeing patient daily, day in and out in our OPD and ICU also. With the same cases you have described, the case 1 and 2. Usually we have pancytopenia every time. Then we used to send all the viral markers, whether it may be dengue, chikungunya, script, typhus, whatever. Then first, everybody thinking of this just the sepsis because of the infection. But now this is eye opener for me also, as this topic is very relevant nowadays. because I have never seen anybody who's making the diagnosis of this HLH. But this is very good, excellent presentation, ma'am. Thank you so much. So I think now we have to take the question answers. So in chat box, one question from Dr. Ria, and she's asking that do we need bone marrow biopsy for every patient to make a short diagnosis?
Yes. So actually, I have mentioned specifically that the bone marrow biopsy and its results, where we will see that there is hemophagocytosis, it is good to have that thing, but these patients are often so sick. And if there is coagulopathy, sometimes you may not be able to perform that bone marrow biopsy. So, bone marrow biopsy for every patient for a sure diagnosis may not be required if you go by the age score. So, if by the age score, if you find that at least five of the criteria are getting satisfied, then you know and you can start the therapy. Problem is that if you do not have access to all the investigations that are there for the diagnosis of this condition, then you may have to resort to bone marrow, which is being done by us medical professionals, and it is available in every center. However, in every center, you may not have tests for ferritin and fibrinogen, etc. So, this is a clinician's decision and according to the resources available to you. But what I can say is that it is not mandatory for diagnosis.
Yeah, thank you so much, ma'am. Next question is from Dr. Neha. She wants to ask what are the prognostic markers of HLH?
Yes. So, as such, the patients who are coming with HLH, at least when you are diagnosing it, it has a poor prognosis from the beginning when you are having this. But the criteria which you must have found out that the age score is when your WBC count is less than 1000 and your platelet count which is said to be less than 50,000. So already the pancytopenia mark here is quite severe and that is bad. If your platelet count is very low, less than 10,000, and patient is bleeding, if your patient is presenting with ARDS, which we had in the case number 2, or your patient is having a renal failure, presenting with a renal failure requiring dialysis, patient is in shock, patient's blood pressure is falling beyond the measurable values, in that case, your patient is having a very poor prognosis.
So yes, the clinical picture is also as important as the other markers, right, ma'am? Another question, is there any role of IVIG in this HLH syndrome?
Well, the HLH syndrome, if it is in the autoimmune category, that is the mass, not all HLH, like primary HLH, which is due to genetic mutation, no role. If it is a malignancy, no role. But if you can find that there is an autoimmune basis, then there may be some role.
Then again, somebody asking the role of plasmapheresis.
Plasmapheresis, I do not know. I'll also ask Dr. Daria if there are any papers. However, whatever I went through, their plasmapheresis has not been mentioned as to be very helpful.
So, yes, ma'am, I think you're right. Because if there is a autoimmune disease is per se there, then sometimes we can think of that because both the things either you are going for the plasmapheresis or IVIG. So both are the same things. If you have a plasmapheresis facility, then only if it is a background of autoimmune. Otherwise, per se in HLS, I don't think so that plasmapheresis is the treatment of choice. Oh. And somebody, Dr. Manan Raj is asking how we should differentiate from the DIC.
Okay. So, the DIC is a completely different entity where, apart from thrombocytopenia, there is coagulopathy in the form of an increased APTT and P time, and there, apart from that, DIC has a different set of causes. sepsis may lead to DIC, or some malignancies can also lead to DIC. However, in DIC, if you get cystocytes, if you get a high D dimer, if you have a prolonged APTT and P time, then you may have a problem with the diagnosis. Actually, you are right in a way that if your patient is bleeding from every part and having multi-organ failure, sometimes clinically it may be difficult to differentiate. But once you do the actual blood investigations, you should not be having a confusion between HLH and DIC.
I think DIC may be a part of that one. So no, I think we need not to differentiate at least because there is a sepsis is there. Once sepsis is there, you may have a consumption coagulopathy. So once if you are going for the bone marrow and then we are finding the histiocytic picture, then it is definitely HLH. So regarding the treatment, ma'am, the newer treatment, Empalumab and the anti-cytokine therapy, we are using that tolicizumab, na. So I think it's a very double-edged sword because once if it is because of we have used this in COVID also. So after just patient become healthy, so there are long term complications are there. So what do your take on that? We should start directly once if we have like diagnosed the HLH, or we should do
No,
it as
no,
a in a step like manner.
no. First thing is that the first thing what I will say is that tocilizumab is available, but empalimumab is not available in our center. So I have no idea actually. This was taken as a theoretical knowledge base we have written. I have no idea how it is faring. And I think these are early days to say what is the long-term sequelae of these drugs. But in case of these immunosuppressions, what COVID has taught us that such immunosuppression later on may lead to another severe sepsis or tuberculosis. So ultimately, we lose the patient. However, what I say is that it is better not to use them at the beginning. At least give an initial trial with the well used, well known drugs which have been used from 1994 actually, the dexamethasone and the etoposide. Now, the 2 month, whether the patient will give us time for 2 months, I don't know. But at least in the first 4 weeks, if there is no improvement, one may think of going on to add another one. Ultimately, whenever we are using so many immunosuppressives, we often lose patients due to fulminant infections. That is our experience in other scenarios too. So, this is a very fine balance.
Thank you so much, ma'am. So now you can see that the popularity of this short certificate course, people are here and asking questions. So everybody is interested
Yes, yes,
and they are giving you thank you also.
yes.
So at the last, on the behalf of Dean ICP or President API, Dr. Jyotimay Paul sir, and Course Director, Dr. Sudhir Mehta sir, I again thank you very much for sparing your valuable time. And thanks to all the delegates, all the residents, all the PGs who have joined here. Thank you so much, ma'am. What we need because we'll have a examination also to just they have to pass 50% marks. So we need your one the lecture in the form of the write up of your HLH, and you just send me the 10 questions. So we'll compile all the question, and at the end of I think we are ending in the July first week. So after that we'll keep the examination. So all the residents, please note this. And again, thank you so much, ma'am, for sparing your valuable time. Thank you so much.
Thank you.
Thank you.
Thank you very much for the opportunity and thank all the students and listeners. It is good to have. Thank you.
Thank you. Jyoti sir is there or he has left?
He has left. He has left.
Okay. Thank you, ma'am. Thank you. Thank you, everyone.